Yeah, my first talk is a little bit about history, how it all started, and it started with this gentleman. This is Professor Ulrich Beck, a picture from both of us 20 years ago. This was when I became an assistant professor at our university hospital. And he was at that time head of contrast media research at Schering, now Bayer, and he developed all the contrast media, iopromide, which is ultra-wrist, or also for MRI, the gadolinium was developed by his group. And we discussed how to use contrast media for local drug delivery. This was the idea we had. And we combined the contrast medium with paclitaxel because we had it in the lab. This was, if we had another drug, we would have used this one. So this was also by chance. And we did cell culture experiments, found that already short into incubation with such a formulation inhibits the growth of vascular smooth muscle cells. And so we went into a porcine restenosis model, experimental stent implantation at day 0, and a control at 4 weeks, and if you do controlled oversizing, you induce neointimal proliferation. And we found that when we added the paclitaxel to the contrast medium, there was a dose-dependent reduction of this neointimal formation, despite the short contact time we had at day 0, and this result was seen at 4 weeks. However, we realized very quickly that it's difficult to control how to bring the exact dose of drug in a specific territory if you inject it. And therefore, I had the idea in 2000 if we could use this concept to coat balloons. Professor Speck said, no, it's not possible, we can't do this. But nevertheless, he did some experiments, and we had, in 2001, several prototype DCB, went again in this animal model with bare metal stent implantation. And the interesting thing was that if we coat balloons with pure paclitaxel, only with an additional solvent, there was no effect on neointimal proliferation at all. However, if we use the contrast medium as an excipient, how we say today, we found a dose-dependent reduction of neointimal formation by coated balloons at 4 weeks in this model. So this was very interesting. And we discussed how we can translate those findings in the first clinical trial. And at this time, it was much easier to do a first-in-man trial in Germany than it is the case today. And at this time, in 2002 and 2003, bare metal stent restenosis was an unsolved medical problem. We had only balloon dilatation to treat it. Drug-eluting stents were not yet available, and so we designed this small trial, Pacocat ISR1, 26 patients in each group to treat bare metal stent restenosis either with an uncoated balloon or with the paclitaxel-coated balloon, and the result was very impressive. At 6 months control angiography, we could reduce late lumen loss from 0.74 to almost 0. And I know that one of the reviewers from the New England Journal was Patrick at this time, and helped to bring this at this high level, despite the fact that this was really a limited number of patients. And this trial is now seen, this is a paper by Adnan and Robert, years ago in The Lancet, has been seen now as one of the landmark trials in the history of interventional cardiology. In 2004, we had no funding anymore, and we looked for partners from the industry, and Dr. Boxberger, who is also here, visited me in Hamburg. And in this year, they were looking for a histology lab to doing drug-eluting stent experiments. And he was interested when I presented him those preclinical data at this time. And BBraun decided to support this project. And this was the birth of this sequent please DCB. It was very important to start with smaller trials and different indications to get some feeling how this concept works, what are the applications. And one of the trials was a non-randomized trial, the PEPCAT-1 trial in small vessel disease. We had only balloons with 2.5 millimeters in diameter, so we had to adjust the balloon size by inflation pressure, and we had no idea what to do in cases we have relevant dissections. We only said, okay, you can put a bare metal stent in it. That's all what we knew at this time. Franz Kleber included most of the patients in this trial, and the result was surprising. Number one, the majority of lesions, about 80%, could be treated by DCB only. There was no need for additional stent implantation. And number two, those lesions that require stent implantation did not really good. So this was one of the important lessons and was the precondition to develop this concept of DCB only, that we do first lesion preparation and then decide if this lesion requires stenting or if it's possible to treat it without stent implantation. And this was then the first publication of this. We had the first Berlin meeting in 2010 for DCB, and with the help of Patrick, we can then do a supplement in Euro intervention where we summarized many of the reports from this meeting. And one was this recommendation, the first recommendation, to start with pre-dilatation, now we call it lesion preparation, and then decide between DCB and stent treatment. At this time, we had no idea that this also could be beneficial to improve the outcomes. It was only a tool in the beginning to differentiate the lesions for the respective therapy. One of the interesting findings that came later up, and this has been done together with Franz, was that we have seen that the lumen improves in many of the lesions over time, and we looked at it systematically, and what we really saw was a shift of the MLD distribution from the left to the right, and this was really new, because with all other treatment options, especially with stents, you see some loss of lumen over time, but never see an increase in lumen, and that was really new for this treatment. We also looked at larger randomized trials, and this was together with Raban, the basketball small 2 trial, where we looked in coronary arteries less than 3 millimeter in diameter, compared the sequence neo with the Xines and the Taxus element stent. And here we can see over 3 years that there was in MACE, in terms of MACE, we have discussed earlier that there was some noise because of intervention in other arteries too, but we could see that up to 3 years there were very similar outcomes with DCB only versus stent implantation. Another interesting thing to see was, Patrick has shown Transform 1 already before, is that the sequence please, this initial coating, is still the standard. Most of the trials that compares DCB, which is other, uses the sequence please as the control group, and this was also the case here in Transform 1. And what you can nicely see is that here with this coating, with higher dissection grade, you have a reduction in late lumen loss, which was not the case here with the sirolimus-coated balloon. Also interesting is, of course, to look at drugs different from paclitaxel, and this was a huge preclinical program we did a long time ago. We looked at different formulations for sirolimus, and here again we found that with crystalline coating you can reach a longer persistence of the drug in the vessel wall, and this has also been investigated in clinical trials together with our friends from Malaysia. First here in instant restenosis, where you can see that at 6 months late lumen loss distribution, late lumen loss was the same either if we use the paclitaxel-coated balloon or the sirolimus-coated balloon. But if we go to de novo disease, that's another lesson. If you compare again those both DCB, both work very well, but this effect of lumen enlargement is more frequently seen in the case of paclitaxel-coated balloons. There was this safety debate initiated by the Katsanos meta-analysis from peripheral arteries, and at that time Katsanos also wanted to do such an analysis in the coronary arteries, and we discussed this all together and decided to do our own meta-analysis. This was also big work from Davo, who's here in the panel. And we could show that the safety signal from the existing data at this time is not present for paclitaxel-coated balloons in the coronary arteries. We see a lower rate of acute myocardial infarction within the first year, which also supports that DCB-only treatment is safe. You can sleep at night. There's no risk for acute or subacute vessel closure, and there was also no mortality. This has also been shown today before the distribution, before the COVID pandemic. Japan at this time was already with a stand to DCB ratio of 1.4. Meanwhile, they are going to 40% DCB use in practice, and all Asia is increasingly rapidly. But I think also in conservative Europe, we are starting increasing DCB use more and more, and this is this market projection, which has already been shown before, that it is estimated that at beginning of the 30s there will be an equalized use between DCB and DCDS. So the journey was really a local innovation we did together with Professor Speck here in Berlin. Meanwhile, avoiding permanent implants is a new goal in interventional cardiology. If you have a crazy idea and you are convinced that it will be working, it's worth to follow this path. And I think we are now in the stage that we can discuss a broader use of DCB. Thank you very much.